Hypertrophic cardiomyopathy, or HCM, has been this central, fascinating topic in cardiology for generations, and for a really good reason. It's a disease that's just characterized by this incredible mechanical complexity, and at the same time, this devastating clinical potential. So in this explainer, we're really going to deconstruct its pathophysiology and how it shows up in patients. This image, it's from a football match back in the late 90s, and it just perfectly captures the central problem of HCM. You have a seemingly healthy athlete, at the absolute peak of their physical performance, who then succumbs to sudden cardiac death. This kind of event really underscores this profound mystery in the heart's mechanics that we're now going to unravel together. The real core of this mystery lies in a fundamental genetic paradox. You see, HCM is the most common heart disease caused by a single gene, yet it has what we call incomplete penetrance and variable expressivity. Now, what does that mean? It means for the vast majority of people who carried a faulty gene, the disease remains completely silent. So genetically, HCM is an autosomal dominant condition. That just means you only need one copy of the pathogenic variant to be at risk. The mutations we see most often are in the genes that code for the heart's muscle proteins, the sarcomeres. Specifically, we're usually looking at myosin-binding protein C, which we now know is actually slightly more common than mutations in the beta-myosin heavy chain gene. And this slide really highlights a critical point, the sheer difference in how this disease shows up. An estimated 95 to 99% of people with the gene are totally asymptomatic. So our entire clinical focus, and really the subject of this whole analysis, is that small 1 to 5% who face the really serious outcomes. Progression to heart failure, dangerous arrhythmias like atrial fibrillation, or the worst case scenario, sudden cardiac death. So now let's take a look at the heart itself. To really get a handle on HCM, we first have to define exactly what this muscle thickening, this hypertrophy, is. It's not just a simple thickening of the whole heart wall. It's a very unique, asymmetric, and hemodynamically significant type of hypertrophy. The clinical definition is really strict. For a diagnosis, you need to see that the left ventricular wall has thickened to 15 millimeters or more, and the chamber itself isn't dilated. Now, crucially, this thickening has to be unexplained by other things that would put a strain on the heart, like chronic high blood pressure or a tight aortic valve. By definition, it's an inappropriate hypertrophy. And that leads us to a really critical differential diagnosis, the physiological hypertrophy you see in an athlete's heart. An elite athlete can also develop a thickened left ventricle, but it's a fundamentally different adaptive process. As you can see here, an athlete's heart gets bigger with a large, flexible cavity to handle more blood flow, and its diastolic function stays normal. In contrast, HCM features a small, stiff, non-compliant LV cavity and impaired diastolic filling. It's a maladaptive change that doesn't go away with detraining. So, the hypertrophy in HCM has three defining features. First, it's asymmetric. It typically involves the septum between the ventricles and the front wall while sparing other parts. Second, it's inappropriate. It happens without a logical cause, like high blood pressure. And third, its obstructive nature is variable. In fact, we don't really use the term HOCM for obstructive anymore because only a subset of patients actually have a significant obstruction. Okay, so this unique anatomical setup leads directly to the core pathophysiology. We're now going to explore the two main mechanical consequences that drive all the clinical symptoms of this disease: diastolic dysfunction and dynamic left ventricular outflow tract obstruction. First up is diastolic dysfunction. So the thickened muscle grows inward at the expense of the ventricle's volume. A smaller, stiffer cavity means that for any given amount of blood, the pressure, the left ventricular and diastolic pressure, is way higher. This pressure then backs up into the left atrium and the lungs, which directly causes dyspnea or shortness of breath. A fast heart rate makes this even worse by reducing filling time, and all that chronic pressure stretches the atrium, making it a perfect hotbed for atrial fibrillation. But the most hemodynamically dramatic part of HCM is the dynamic obstruction. So what's the key mechanical event, the hero of the story, that causes this obstruction during the heartbeats? The key mechanical event is known as systolic anterior motion, or SAM. This line illustrates it perfectly. That asymmetrical septal hypertrophy, or ASH, bulges into the outflow tract. This narrowing forces the blood to accelerate into a high-velocity jet. Now, because of the Venturi effect, this jet creates a low-pressure zone, which literally sucks the anterior leaflet of the mitral valve right into the path of the blood. This event happening mid-systole is the key process that creates that dynamic obstruction. The crucial point here is that this obstruction creates a measurable pressure difference, a gradient, between the main part of the left ventricle and the aorta. A gradient over 30 millimeters of mercury is considered hemodynamically significant, and it directly correlates with how severe a patient's symptoms and prognosis are. This unique pathophysiology creates an equally unique sound when you listen with a stethoscope. The LVOT obstruction produces a harsh crescendo-decrescendo systolic murmur. At the same time, that SAM phenomenon by pulling the mitral valve leaflet out of place causes a secondary leak, mitral regurgitation, which produces a blowing pansystolic murmur. Hearing this combination is a classic hallmark of HCM. So this brings us to the clinical diagnosis. How do we take all this understanding of the mechanics to the bedside? Well, the key lies in something called dynamic auscultation, using physiological maneuvers to actually change the murmur and confirm our diagnosis. Patients usually present with that classic triad of symptoms: exertional dyspnea, angina, and syncope, all direct results of the obstruction and the diastolic dysfunction. On examination, the physical signs are driven by SAM. It creates a pulsus bisferiens, which is a double-peaked systolic pulse, and a double or even triple beat at the apex of the heart. And of course, palpitations might be a sign of atrial fibrillation. So if you suspect HCM, how can you confirm it right there at the bedside? You can actively interrogate the heart murmur just by changing the loading conditions of the left ventricle. This is the essence of dynamic auscultation. Any maneuver that decreases preload, so less blood returning to the heart, like when you stand up from squatting or do a Valsalva strain, that reduces the LV volume, makes the obstruction worse, and increases the murmur's intensity. On the other hand, maneuvers that increase preload or afterload, like squatting or a sustained hand grip, expand the LV cavity, lessening the obstruction and decreasing the murmur. It's a classic finding. In fact, HCM and mitral valve prolapse are basically the only systolic murmurs that get louder with a Valsalva. Now, while clinical skills are absolutely paramount, the gold standard for a definitive diagnosis is the transthoracic echocardiogram. With 2D imaging, we can directly see and measure the asymmetric hypertrophy, confirming that wall thickness of 15 millimeters or more in a non-dilated ventricle. Then, Doppler lets us quantify that LVOT gradient. Management follows a very clear, tiered strategy. First-line medical therapy is usually negative inotropes, primarily beta blockers, to slow the heart rate, improve diastolic filling time, and blunt the hyperdynamic contraction that makes the obstruction worse. For patients with high-risk features, like a history of cardiac arrest or massive hypertrophy, an implantable cardioverter defibrillator is indicated to prevent sudden cardiac death. And finally, for refractory symptoms despite maximum medical therapy, we can do invasive septal reduction, like a surgical myomectomy, to just resect the obstructive muscle and provide definitive relief. And this brings us right back to that central dilemma of hypertrophic cardiomyopathy. We have this deep, incredible understanding of its mechanics and effective, life-saving treatments for the few who are at risk. But if a genetic disease remains completely silent and benign in up to 99% of the people who carry it, what are the profound ethical and practical implications of widespread screening? It's a question that medicine continues to grapple with.